I just want to say that ignoring how to do telehealth well is a privilege. So, being in a position where you feel like you can make a statement to say, we don't need to do telehealth, I want to ask a different question entirely. I want to ask the question, how do we do this well? Because if we can't figure out how to do this well, I forget the stats right now, but it's a significant portion of people who get referrals to physical therapy and never show up. They ignore the phone calls, they don't follow up. Why aren't we asking why? And why aren't we asking, okay, are those things that we can do something to address? I am not okay with saying, well, I don't want to offer them subpar care, so I'm going to do nothing. What I need to do is ask how. How do I solve this problem? How do I figure out how to treat them? Because just saying, if I can't use my hands, no, that's not enough of an answer. Because when I'm looking at stats for telehealth, I personally am not looking at the manual hands-on stuff because I know I'm not replicating that. I'm looking at biopsychosocial interventions. I'm looking at the stats for telehealth and mental health interventions. I'm looking at those, and that's a lot more promising. And so when you're looking at those kinds of things, because those are the types of interventions that you're doing when you're looking at telehealth, you're doing the education, you're looking at mental health, you're looking at the stress, the anxiety, you're in one position. You can still see position and posture and movement.
Hi, my name is Rebecca Seagraves, and
And my name is Jenna Seagraves.
we are the co founders of Enhanced Recovery After Delivery. And we try to put on one of these panels at least once a year that really addresses probably the most common question that we have received since starting a pathway that really expanded access in the hospital setting to occupational and physical therapy during high risk pregnancy and after birth. We both worked at Texas Children's Hospital in 2020 together, treating this patient population and other patient populations after hysterectomy, endometriosis surgery, definitely during high risk pregnancy, and immediately after birth, during the height of the pandemic. And then Jenna and I have started these programs now following in the footsteps of so many before us. For me, it was Dr. Ann Krogan who started offering these services in her hospital that, provided birth support for 90 patients a year. And we expanded that idea to a hospital that had over 500 babies born a month. And so we've just been really excited. And it's just from our experience of working with occupational therapists. We're both physical therapists, but it's from our experience of working with occupational therapists that it really brings us joy to bring on our panel guests tonight. And it's with great honor that we bring them up so that they can introduce their practice themselves, where they're located, and what settings they have actually treated this patient population during pregnancy and after birth. And it really have an enriched discussion, if you will, on the differences between occupational therapy and physical therapy when it comes to maternal rehabilitation. And so, without further ado, please, I will have the first guest come up. Kelsey, welcome. So happy to have you on here. Please introduce yourself and your practice.
Hey, I'm so happy to be here. Thank you so much for asking. I'm Kelsey Mathias. I've been an occupational therapist for 10 years. Immediately dove into pelvic health from the get-go. I saw it on field work and how it changed lives. And when I saw that huge transformation in how people could access their world around them by impacting pelvic health, like I was sold like hook, line, and sinker. I pretty quickly went into into maternal health, and it ran a private practice in Colorado Springs, which is where I live currently, where I did mobile outpatient care in people's homes. And it was surrounded by pregnancy and postpartum. And I saw so many things that would happen in people's daily lives by meeting them in their context, in their environments, and seeing what was going on. What's the question after the question? What's going on beyond the protocol? And so that's where I formed a good chunk of my practice. And currently I work at a population level as a contractor for the US Army, where I'm looking like, what can we do in this funnel of treatment to treat people at a population and then a generalist level before we hit to the specialist level, because with military, we just don't have enough people for how many people need treatment. And so that's what I'm looking at now. And I do have to say, anything I say tonight does not reflect any of the opinions of the government, and all opinions are my own. That's all I got there.
Kelsey, that's incredible. Talk about impact too. Getting at getting, expanding now to the population aspect.
I mean, question on that. Can we
Yeah.
just
Yeah.
clarify exactly? Wait, what did you just say?
I work population level interventions as a contractor. And so what I do is with the Army, I help run a program called Pregnancy and Postpartum Performance Training. I train Army leaders, so not just medical professionals, to help not just physical training, but an overall holistic, the spiritual, the nutritional, the sleep, the mental, hitting all of those points from a performance population level of intervention. On average, with Army, it's about 10,000 soldiers a year. This is public information, so I'm not hiding anything. And so looking at like about 10,000 soldiers annually having babies, and then also collaborating across disciplines with other, like with Navy and with Air Force. And so you're talking literally like tens of thousands of people when we take that big picture view of what can we do to help change populations and help improve access to care and maternal health.
Kelsey, before I bring the next panelist on, I have to say, from a physical therapy standpoint, where we have been really treating at the institution level, fair to say, right?
Yeah.
Do you find it kind of even hard to have this conversation on, well, what is the difference between OT and PT because you're working at such a bird's eye view? I mean, I had to drag you onto this panel, which I didn't. You were so happy to just like participate, but like I almost feel like thank you for coming down. And to kind of really just a fundamental level of having a conversation that I promise you we've been having for almost 4 years.
And it ranges that variety of like, there's at a population level, I don't care if it's a PT or an OT. I just want people with that general education information that's going to have to pass across spectrums. It could be an athletic trainer. I am pro personal trainer, strength coach, chiropractor. I want people to know more about maternal health and empower people at all of the different levels. And then you get into the more subspecialized levels. We're like, okay, in acute care, we have more defined positions. In outpatient, you have like lymphedema specialists, and they can be PTs or OTs. And I'm jumping ahead of myself, but like that's where the answer of what's the difference of PT and OT, it's going to depend on the context, the environment. Here I am sounding like an occupational therapist. The individual in front of you, the provider, it's going to depend on all of those things when we're talking about what is PT looking like versus OT.
Do you feel like it's been defined too long as what is the discipline able to do versus what does the person need?
100%. It has been so provider focused instead of client focused
Mhm.
that sometimes this conversation can be frustrating to me because we're centering the experience of the provider, which is not what healthcare is supposed to be. We're supposed to be centering the experience of the person in front of us. So yeah, in some ways this conversation gets a little frustrating to me. Um, but I understand why it's necessary. And I also understand why in some instances we need division of labor.
I'm going to bring up Ive and just please introduce yourself. I'm so happy to have you on as well. Thank you.
Hi, I'm Aide Rosado. I am an occupational therapist. I have been practicing for 11 years. I started with a huge background in neuro. I worked at Tier Memorial Hermann on their brain injury unit. And so I got to learn how to gait train for my PTs. And so I feel like I got a very well-rounded education. Well, I feel like the majority of public health providers had an experience that made them like fire up about serving this population. And for me, it was my C-section. I mean, I knew all the things as an OT, or I thought I did, and it had left my brain as soon as the child came out because I was just focused on keeping this child alive. And when I went back to the hospital in 2019, I said, "Why aren't we seeing C-sections?" At the very least, I feel like, in all honesty, it should be every pregnant body. Um, but why not there? My director at the time kind of laughed me off and just said like, huh, yeah, okay, whatever. And so I've been in acute care now for 7 years, and we started the pilot program in May. And so the idea is that the OT department is actually going to take ownership of the pelvic health program because the PTs are already saturated. When they found out that there was going to be another program, they all rolled their eyes. They're like, oh gosh, here's another thing we're going to have to do, because they see them pre-op and post-op and the BIDs. And so that's how I sold it to my director, to my supervisor, because she was just like, well, do you want a PT and OT? And I was like, well, I think we should really take ownership of it. And then if we as clinicians don't feel comfortable with the symptoms that we're hearing, then, definitely we'll get PTN. But as of right now, we're still doing PT and OT, and then whoever gets the order first, and we run with it. So what I'm doing as well is I'm providing telehealth. I don't have like a constant caseload where I'm depending on that. At this point, it's my passion project. And if somebody vibes with my style and how I approach things, then whoever wants help, I'm here to give it to you, because I've seen the impact of healthcare policies, especially in Texas. Everyone knows how crazy we are over here. But in the last 5 years, especially since COVID, we've had a lot of rural hospitals closed down. We've even had labor and delivery units being shut down in San Antonio, which is a huge loss for the women here. And we have tons of rural areas around San Antonio. When I worked outpatient, I had patients coming in 3-4 hours away, which is insane because there was no other provider. And so for me, being able to provide telehealth and seeing, okay, what can because I think Kelsey touched on this already. There is a generalist thing within pelvic health. And that was one of the things because what I do now is we do one, teach one, or I teach one and then they do one. And they were like, oh, that wasn't that bad. And I'm like, yeah, you do this already. You literally do all bed mobility. You check orthostatics. You check how well they can transfer. You ask about family support. These are all things we're already doing in acute. And then all the extra little specialization things, I mean, that can be taught in the journal clubs, and that can be taught by, observing. And the goal, hopefully, is if we can get it off the ground and it's successful, I will be able to train the entire hospital system so that everyone in our hospital system is able to have maternal postpartum health, which is insane. Of course, I've got pushback immediately because they were like, we don't have the staff. We are very lucky. We have like 70 people in our department. But some of the hospitals don't. So I was like, let's do it. Like, let's try this one. I know it's going to work. And, hopefully we'll be able to get all those other people in the other hospitals in our hospital system. So yeah, there's so much. I feel like PT and OT we complement each other so well. And like Kelsey said, depending on your training, most people, when they work with me, they're like, you seem like a PT, like other clinicians, you seem like a PT. And I'm like, well, it's probably my neuro thing, my neuro background. And I also understand I mean, I remember I've had PTs tell me like, oh, you lift patients? And I'm like, what do you mean I lift, like transfer them? Like, yeah, like, why wouldn't I? I'm like, how do people get dressed if they cannot move? Like, and so, I mean, that can be a little offensive in my opinion, but I can understand that depending on the clinician, you can have a lot of experience or you can have not so great experience. I know for me, orthopedics was the daunting thing for me. And then I took a course and I studied it and I asked my PT friends. And I think the beautiful thing about pelvic health is that we have a beautiful community of all disciplines, PTs, OTs, chiros. I mean, you can even have STs because some women are having strokes postpartum, right? So, you're having your cognition impacted. So it's not, I'm going to save everybody. No, I'm going to save you not save you. I'm going to help you, empower you to the point that I know that I am able to. And if I know that I can't, let's refer you out, because I'm not going to hold somebody back because I'm pretending like I know something. No, thank you. That's my license. At the end of the day, it's the client in front of you. It's not my ego, right? And so that's my soapbox. Thank you.
I think this is kind of that critical point in the conversation. Like we're so small in the grand landscape of healthcare. We have so little at the table when it comes to, and I believe this was actually coming from Sarah Lyon, just released a report, through her platform OT Potential. That when you look at even physical therapy and occupational therapy together, in terms of the momentum that we have of lobbying power, of generating any kind of revenue or support or funding or whatever it is, we're like a blip on the graph, compared to these huge industries. And so when we're talking about differences between PT and OT, and you hear the statement, oh, you're like a PT as an occupational therapist practitioner. I have to say, just from my experience, and I know Jenna can add her own, and I've said this before, in different, cases, but as a rehab, tech, before I even went to PT school, I learned about pelvic health from an occupational therapist. It was just working with a patient after a spinal cord injury, who was desiring, to also get pregnant one day, even after her injury, and just asking so many questions and hygiene, and will I ever feel anything, or is there anything I can do up here where I can feel, and wanting to have a relationship, an intimate relationship again with her partner. I mean, it was just amazing. And I was mesmerized. I didn't even think they needed me. And I was just in the room, just like soaking it in. An occupational therapist was just so, I mean, just the ability to explain to someone in the most traumatic of cases and meet them where they are, psychologically, just emotionally, just even spiritually, about the meaning of life, and what all this means, and then the chance to for motherhood, and then also then seeing that working with occupational therapists, just kind of being blown away that, wow, I did not assess that, I didn't even pick that up on that. Oh, I didn't see that there was maybe some concern there, before a person went home after an unplanned C-section, and an occupational therapist was in the room evaluating with me. I was learning and soaking so much. So when I hear an occupational therapist practitioner almost being, I took it as if it was a praise, like,
Right.
which is great, but I almost feel like there is also this limited understanding of your scope.
So, yeah, I actually have a story that I wanted to share that you reminded me of this, both of you actually, Ive and Rebecca. So, my background, I'm a neurospecialist, and so that's really my area of specialty. And when I was working in a neuro outpatient clinic, there was an individual, they had had a stroke, and so they were receiving all 3 disciplines, as part of their rehab, and the occupational therapist was going out on vacation for an entire week, and so we were trying to coordinate that week's appointments to at least make sure we could get PT and speech in. But the son of the patient, who was, often the one he went to every single visit, and he was often the one we communicated and scheduled with, he looked at me and said, "Well, can't you just do the OT?" And I went, "No, I cannot, because I'm a physical therapist. I am not an occupational therapist." But so almost in that same regard, it was kind of like, do the patients and their families even really know how it's different? Or are they just seeing that we're helping their loved one, or that we're helping them as an individual? And as long as their needs are being met and their goals are being worked on, that's really what they care about at the end of the day, right? So, anyways, I was kind of like, why would they even ask me that? But in a way, maybe I should also take it as a compliment. Yes.
I wanna really, like, just get a sense and just an understanding of just really true scenarios of just, where you in your setting, specifically, even in the hospital setting. I mean, I think, Ave, you gave it a wonderful example of, while, like, you're transitioning people's understanding and mindset, even around cesarean recovery and probably other birth recovery types, to where you can see the light at the end of the tunnel, and that tunnel or that end of the tunnel is where you, as an occupational therapist practitioner, will be training the entire health system. And so, talk about population level, which is just huge and massive, systems level, and then me as an individual facing therapist who's working at the individual level. I have to get a better understanding for myself to be able to navigate so many of these questions that we just get on and on and on. Can we just maybe just have a powwow of what does it look like from an OT standpoint and then a PT standpoint, which Jenna and I can absolutely share on. But what does it look like in terms of just your eval coming into the room, from that patient's experience, and then like meeting them where they are? How would you do it differently than us as physical therapists? Can anyone take that on?
And give a potential case,
Gosh.
or I only ask because
I have so many. Oh my goodness. So yeah, no, there's my first experience in the acute care setting, working with a physician who lost more blood than expected during her delivery, went in back to the OR after C-section, went back in. Unfortunately, had to have a hysterectomy, and
Mhm.
been it to the ICU. And even in the ICU, baby's in the NICU, she's already thinking about breastfeeding positions, not the um, point of her journey that we actually focused on that, but we did on mother baby. And so I was able to follow her from delivery really onto discharge. And so we were really focusing on just even sitting balance, looking at her vital signs, making sure that she could just tolerate that activity edge of bed before we even transitioned to the recliner. Eventually, that was kind of the goal of those initial sessions in the ICU, was to make sure that we can at least transfer and she was still stable, because she had lost quite a significant amount of blood. And so once we were able to see her transition over to mom baby, a lot more activity, a lot more just kind of curiosity. What is this going to look like? How do I make sure baby's not kicking me? Because a vertical incision was enormously long. And so I'm here learning the football hold, because I really, even at that time as an acute care therapist, outpatient women's health therapist before that, had really never navigated breastfeeding positions with anyone that early. There's just no way. And so I was figuring it out myself, looking quite honestly, like on my phone for examples and saying this one works. My preceptor was also just guiding me and guiding the patient. And I was learning a lot. And so those are the kind of things that we were really focusing on, was addressing ADLs, which I didn't really even put together back then. Well, ADLs, that's newborn care. That is the breastfeeding positions. These are the activities that she's going to be doing. This is the occupation that she's going to be doing as a new mom in the midst of a surgical recovery that I was really focused on helping her heal from. And so, from an OT standpoint, if you were in the room with me, it would have alleviated just so much kind of the stress. It probably would have been probably really uh, happy to see what your eval would have been, because it probably would have caught, so much. I don't think I really gave space to even just process the loss of her ability to expand her family beyond her one child. The traumatic delivery of losing almost so much blood that she ended up in the ICU. Her baby was in the NICU. And then that moment where they were bonded together. It's just, there are things that I think back now, like, wow, did I make any space for her to even talk about those things in my eval? And what would my OT counterpart have done? And so, yeah, I mean, that's kind of an example of, if, Kelsey can.
take that case and run with it, you
Oh,
two.
boy.
That's where, like, I would have come into the room and I would have just paused. I would have held a hand. I would have been like, how are you doing? What's going on? And I think OTs, when they come to the table, they bring this magic of like, okay, we've asked the questions, we have our checklist done. Let's ask those questions after the question. Let's follow up about what's going on. Why did you pause there? Is everything okay? What's your family dynamic look like when you get home? You just went through a lot. Do you have some support? Do you have a church or a friend group where we can set up some meals so we can get some meals sent to your home? Can we like, is your partner supportive? What's his role in this? Do you have family nearby? Asking, like, what does that structural support system look like? Do you already have kids at home? Like, in that instance, maybe not. But if they have kids at home, do you have some backup care? Because this is going to be a lot. You're caring for a C-section. You just lost a lot. Do you have meds you have to take after? Where do you store your medications in your house? Are you the type where you forget to take your medications? Okay, do we need to set some reminders right now on your phone before you leave to go home so it's easier for you to remember? And so those are the other things, like, as I would come in and bring into the room, which, by the way, like, I was looking up stats because I'm nerdy. PT alone in acute care and other settings shows improvements, reduces readmissions. OT alone, same thing. Do you know what gets the best results? OTs and PTs together. When both OTs and PTs are working in acute care settings, that's when we're getting the most bang for our buck and reduced admissions. We need you coming in with your perspective. That OT might sit there and be like, oh, we talked for like 30 minutes about, XYZ, and we have this plan. And oh no, I have to go back in with this handout sheet about how to do like scar management or their incision or whatever it is. I mean, hopefully, like, we can regulate ourselves enough, but realistically, hearing from experiences of others, sometimes we lean more towards that end. And so we bring a lot of humanity into it. I think about it like, why do chaplains versus social workers exist when they come into play? Because social workers they're both addressing some meaning, some purpose, some support systems, and they both serve their role. Chaplains might be harder to measure sometimes what they're doing than what the social worker is doing, but they're both going to be on the team. Some might feel more comfortable with the social worker than they feel with the chaplain. One might be more appropriate than the other in that scenario. And so when I look at like OTs and PTs, what we're bringing into the room, some might feel more comfortable with Rebecca than they feel with me, and that's okay. And I'm not offended. They might prefer from maybe another provider a more strict approach, and I might be too warm for them. And so, like, we're bringing things to the table. The data shows us that we need both of us when we can. And in acute care, that's the opportune time to get both because you have them captive. Once they go home, it's a whole lot harder, time commitment wise, to have outpatient. Okay, outpatient who really wants to show up for PT and OT. So there's going to, by nature, be a little bit more overlap if we're going to practice well and center our clients and be respectful of their time, their energy, their finances. But acute care, we've got them. It's a bundled payment. Let's take it. Let's reduce the readmissions. All right. That's what I got on that.
A nurse reached out on LinkedIn, nurse leader, I should say. And she was just like, hey, I see, difference OT, PT, got it. We definitely, I mean, I think that just the overall, um, understanding and sentiment from our healthcare partners and providers are pretty much at the standpoint now that they're not so much as resisting us, but they're just like wondering how are you going to deliver this? How are you going to help us meet the needs of this large population that we're not able to serve just with our own disciplines? No one would really question. I'm just laughing as I say this. If social work needs to also be there, if the chaplain is there, I mean, like
Right.
we're doing
Right.
things really as a detriment to our own profession, but then also as kind of our life saving device. Like, I have so many people to see. Do both of us need to be in this room after,
Right.
the case that we just talked about? But what the nurse leader's point was and question was, well, do you also address the needs of the infant, the baby in the room? Because once the baby was back from the NICU, we were only just worried about positioning. We didn't even address mom's ability to carry and walk with her newborn for safety. We were just really worried about her safety, just navigating with the walker, making sure that she could go home and have a place where she could, be able to stay until she could get up the stairs. So there were so many things that we just left uncovered because of the discharge constraints, because of all of it. And so, from a home health perspective, when I started doing that almost a year and a half later, it was just eye opening. Like, wow, I missed so much in acute care. But under the time constraints, I sent them home as safely as I knew would be a discharge location with the support that they needed. Did not do home management, med check. Uh,
Mm-mm. Nope. That
uh,
that medication question, Kelsey,
yeah,
mind blowing for me. I'm like, oh,
right.
I've never thought to ask
So
that.
many of
Kelsey,
my patients don't take their meds. Nobody covers med management with them in acute care, or OT does. And if OT is not doing that, the nurse is saying, "Here's your meds," but they're not asking how. They're not asking about
Yeah.
reminders.
And
The
where
question
where
after the
you
question,
keep them,
where
that
do
was
you keep
like
it? Yeah. That it's
Right.
the environment. It's
Ex
knowing asking that environmental perspective that OTs oftentimes bring into the room, that if you ask us out of context, we're like, "We don't know, we just do OT." But, like, it's seeing all of those things that it takes to come into play to bring the whole picture. We're seeing, like, what is the big picture and what are all the things that might come into play that will prevent you from being able to do what you need to do? Can we problem solve that now? Can we do an emergency action plan when we see you on the front end so we can develop, okay, how do we make a plan for, okay, if X, Y, and Z happens, what am I going to do? Who's going to show up? Who's going to support me? Because how much panic have you seen in acute care when crap hits the fan and they have no plan? But then that psychological safety that you can introduce on the front end by developing that plan, maybe you didn't see them before then, but even if you develop that plan while they're still in the hospital, those are things that oftentimes OTs will bring to the table.
I'd never heard of an emergency action plan until you presented to our group just recently at our live enhanced recovery after delivery training about doing that for a mom. You were had already was on your care plan from pregnancy, but you had already kind of established that. And she was ready. Like she was able to monitor her vital signs, catch the fact that something was wrong, and she called you before, she was eventually readmitted back to the hospital. You introduced me to that terminology, emergency action plan. I had never made one with a patient.
To be
Same.
fair, I learned the term from the military.
Ah,
Because they do it. I called it just like your emergency plan. They
right.
call it emergency action plan, and so I'm used to like that's the language I use now. But I just made an emergency plan. It's the same thing that I did when I worked home health. So when I
Mm.
was working home health, building my pelvic floor therapy practice, all of my home health patients would have these little things that we hung on the fridge from the home health care company where it said like, "Where's your list of meds? Where's your emergency contact? Who can pick you up if you can't do something?" And so I learned it from there, and I was still in people's homes, and they're still coming from an acute care setting. So in my mind, I'm like, oh, we just do the same thing. Let's create this thing. Because I was running my private practice, I'm like, oh, this is standard. Like in my brain, it just was standard of practice. This is what we do when we're seeing people come home from an acute
Mm.
situation. So
Uh,
it was
Yeah.
natural.
And it's regardless of population. This is what we do when we see someone come home from an acute situation. So for people who are just like, I don't treat mothers in those conditions. No one's had an unplanned anything. It's just kind of standard. I'm like, what world do you live in? Because there's always birth is so unpredictable, such an unpredictable, wonderful, miraculous, but also, vulnerable experience for that person. And so we can't project. I mean, I think Laura DeRozier, the co-founder of the trauma informed pelvic health certification with Lindsay Vestal, I mean, just said it best, is that we cannot project our own either experience or our own understanding of what trauma that person experienced.
Mm.
And so it would be best actually to have that mindset of an emergency action plan for anyone who's given birth in a maybe in a non-emergent way, but then also in a hospital setting, just being in that setting and then having to transfer all of that home where you're now the sole caregiver in some cases with our single parents, or you just have less support and there's no one maybe around the clock to offer to take your baby to the nursery or whatever it is, or maybe the baby, to that nurse leader's point on LinkedIn who reached out to us, or maybe the baby is in distress. And so do rehab providers, and which one most likely, but do rehab providers also address the needs of the baby? And Ive, I want to bring you in for this because I know that you have done home health, telehealth, acute care, all the things. Do you in your practice address the needs of the baby? Because I'll be honest with you, I can hardly swaddle.
Right.
A baby after I've, kind of disrupted the flow of the bond.
The
Your
the baby
done
over.
burrito. Yeah, I mean, yes, because that's what the mom cares about, right? Like, if there's this, and I obviously I can't speak for all moms. My own experience, my baby came out and I was just like, okay, she needs to feed this many times. I remember I had like sheets putting how much I had breastfed and when was the next time. And, it can get so overwhelming so quickly. And if you don't have safeguards in place, you can, if physically you're not affected too much, I think mentally it can really get in the way of not only, if not the baby, definitely the mom. What I've seen is moms who end up having traumatic births end up being more anxious about going out. They don't wanna expose their babies to any extra things, especially if they've been in the NICU. Um, and creating barriers that sometimes really prohibits going to that outpatient clinic. And yes, maybe you can come every 2 weeks and drive 4 hours. And that might, in and of itself, be a privilege to be able to travel to another city. But there are a lot of people who, again, aren't work, maybe are single mothers and maybe have to return to work in 2 weeks and don't have the support to go to a clinic. Or, I know when I worked outpatient, and a lot of the outpatient clinics here, they always say, like, bring your baby, we don't care. But the reality is, which is actually honestly perfect because you see how flustered they get and you can see, like, you know, so many things that you can help them. So to feel the nervous system and also get them to feel like they're efficient and that they are able to mother and be themselves and be all the things that they want to be. Um, but sometimes baby starts to cry and, you're comforting baby, maybe the therapist, I start moving the baby around and we're like, maybe the baby's hungry. Then they start breastfeeding and I'm like, oh, perfect opportunity for positioning because they're always like this with the baby. It's like, let's get you some positioning. Is that how you're doing it at home? Oh, no wonder that QL hurts because you are sitting on one side more than the other. What does your setup look like? The other thing that you can address even in the virtual health setting is you can encourage their family member, if they have somebody close to them, to video them as they're doing the things that they're doing. Video the house if you can't go into their home. That way you can actually get an idea because sometimes it's kind of like I think I saw like an inpatient rehab meme about this. Like the patient said that there were 5 steps to go into here and there, and it's like a crazy setup to get into the toilet or the tub shower. And I think we have this bias of thinking that everybody's homes may be like our homes. And then you get to their home and you're like, whoa, no wonder you haven't been able to do XYZ. Right. And so I feel like there is so much that we can do, not only in the one-to-one, but being able to go to their homes if you have the ability within your practice, or even having that virtual consult where you can ask them for videos of their gait. So you can ask them video of carrying the baby. One of my consults recently, she had her baby and she's like, I'm getting really stressed out because she's very type A and wanted to have the house clean, but obviously baby's stage 5 clinger. And so I was just like, well, I was like, what do you have? Do you have any baby wearing device? And so I looked at it, I was like, girl, it's too big for you. Like, no, like it doesn't fit you. It doesn't fit the baby. I was like, here are some other alternatives that I've seen other people look at and try it out. I was like, great thing. A lot of places have, good return policies. So as long as we can hopefully get that in, Amazon has been a lifesaver, I think, for many people nowadays. They're in acute and they're like, okay, ordering it now if they're lucky enough to do that. But just even being able, that little thing, the next time I talk to her, she's just like, guess what? I didn't pee myself while I was baby wearing. And I also got to do all my chores and I wasn't exhausted. And I was like, great, that's wonderful. And so why can't we set up people for success and not call it, obviously, not the gold standard, right? Like we know, but why are we prohibiting the access to the care? Because barriers, whether it's financial, transportation, distance, support system, why are we limiting that? Why are we gatekeeping when there are how many million? Is it millions or billions of people in the US? I have no idea. Like I don't check census. There are so many pelvises. Everybody needs, and there aren't enough of us. Just in the numbers that we have, there are not enough of us. So why not all just collaborate and be like, this is what I bring to the table. This is what I bring to the table. And I think that's something beautiful that we can try to do, especially with community outreach and talking to these other support groups. I know, like Kelsey, I was also looking up stats because I was just like, well, let me see Texas maternal mortality. It was not fun to see, but it was a coalition. And, you can also do community outreach or groups with those organizations that get that information out. I just feel like I'm like very peace, love, everybody, unity, right? And I think that at the end of the day, we need to get the care to the people that need it. And if the only way is doing this, then maybe that's what we have, and that's what we're going to work with. If I, at the time that I had my baby, um, there wasn't any telehealth yet. It was like ramping up because it was like, oh, maybe not. It was 2018. I did not leave my house alone with my baby for 4 months because of my anxiety. I was so deathly afraid to leave the house. And looking back, I would have loved to at least have somebody on the internet to talk to. And luckily, Facebook groups and those mommy groups that also scare you, unfortunately. But at the same time, illuminating because you notice, okay, here's this person who has something similar to me, and they were able to get this for themselves.
Mhm.
And so, in that respect, just being able to communicate, I mean, I just feel like technology has really exploded within our therapy services as well. But there's so much more we can do. And definitely in Texas, hopefully it doesn't happen to the entire country. But, after the abortion ban, we're seeing so many more deaths that are 80% preventable. 80%. And that's insane. Moms, we are the backbone of the economy because we're providing the workers and we're supporting the workers and we're workers ourselves. I mean, that's the truth. Why are women being left behind? That's probably another conversation.
It really is.
Another tangent.
You brought up so much there. Like first of all, like you cannot separate maternal care from baby care, and you sharing your own experience of not leaving the home for 4 months. And this is after I want to make sure this is after your cesarean recovery.
Yes. And 18 steps to go up to my second floor apartment. So fun. Mhm.
It makes me recall just a few different things because you touched on a lot, and you did a throwback to kind of a recent buzz around telehealth and pelvic health, and just kind of what is the gold standard? And it's just like right now we are facing an 80% preventable mortality rate in maternal health. And we are having conversations again, not at the Kelsey level, right? Who is
Yes.
just way up here in population health and just looking at the landscape of care during pregnancy and postpartum and doing these readiness programs. I mean, just like on a whole different level, we're having conversations of the quality of care or the setting, and we're trying to dismantle settings at this point. That's if I were to say SNF, rehab, no good, not the gold standard. Everyone needs inpatient rehab, gold standard, Memorial Hermann, or wherever it is, whatever. And we're basically trying to take away settings now where people are receiving care. And so yes, my whole telehealth thing, I'm treating a physician as of maybe goodness, today is Tuesday.
It is Tuesday.
As of last week, I'm treating a physician. A physician is my patient who has been positioning for breastfeeding with one leg bent after her C-section, positioned with her foot on the coffee table, holding baby so she can use her dominant right arm. And I mean, when I tell you for nearly 2 months, she's been in this position, and that is her preferred position. She has shown me no other. We went through every possible scenario. There has been none. She is so tight and so much in pain on that side. And I got her prone over pillows, which I do around 2 or 3 weeks post C-section. I get everyone lying on their stomach over several pillows, having that compression against their incision, having them finally in hip neutral position, finally spinal extension or neutral extension, and just getting them used to being on their belly again after delivering their baby. And she couldn't do it for barely a few seconds. I had a mom today who like wanted to fall asleep while we were in treatment. I said, that's a position for you to do as much as you want, We have some other things that we need to work on though. But this physician could not do it for barely a few seconds, but she got why it was important and why it was important to change her positioning for breastfeeding. So yes, am I treating the mom and the baby? In a way, you can't separate the unit.
Right.
Am I working on positioning? Well, Ive, you just told me you work on positioning. We can't do the same thing. I'm a PT, you're an OT. Oh my gosh. I'm like having a freaking meltdown, I think, out here in these streets. Like, come on, what is going on? And
How
guess what?
dare
Those two
you do
patients,
posture? How
right?
dare
How
you do
dare I
posture?
address posture? Or you address posture, and I'm addressing positioning. And then to on that, I have treated those two patients via telehealth.
Mhm.
Oh, not the gold standard. I just corrected someone's form and taught them about cesarean section recovery and all of this stuff via telehealth, which should be thrown away, apparently. I mean, if we play the defense, we'll always be on the defense. And that's for our nursing teams, our medical teams. If they're asking, what do we do different? We don't take that as being on the defense and putting up our guard. We take it as a welcome. And Kelsey, I mean, I would love to put it back to you. I'm going to search the chats and just kind of see what questions people have been coming through because they have some really great
Yeah.
questions that they've asked. But anything you want to say to that? How are you actually approaching the public and these leaders with the information that you know from your discipline and the information that you know about your physical therapy colleagues?
So I just want to say that ignoring how to do telehealth well is a privilege. So being in a position where you feel like you can make a statement to say, you don't need to do telehealth, or how to, it's not even how that. I want to ask a different question entirely. I don't want to say, is it telehealth or not telehealth? I want to ask the question, how do we do this well? Because if we can't figure out how to do this well, I forget the stats right now, but it's a significant portion of people who get referrals to physical therapy and never show up. They ignore the phone calls, they don't follow up. Why aren't we asking why? And why aren't we asking, okay, are those things that we can do something to address? Having worked my clientele when I was working primarily as a face-to-face person here in Colorado Springs, I saw Medicaid and TRICARE. Those were my people. Those are oftentimes not the people that are being seen by manual, hands-on therapists with cash pay practices, which is fine in and of itself, right? But we have to think we can't ignore a whole other entire subset of the population who's on Medicaid, living in the rural mountains of Colorado, who can't get access to care. They don't have the money to put in their gas tank to drive to Colorado Springs to see me, right? I am not okay with saying, well, I don't want to offer them subpar care, so I'm going to do nothing. What I need to do is ask how. How do I solve this problem? How do I figure out how to treat them? Because just saying, if I can't use my hands, no, that's not enough of an answer. Because when I'm looking at stats for telehealth, I personally am not looking at the manual hands-on stuff because I know I'm not replicating that. I'm looking at biopsychosocial interventions. I'm looking at the stats for telehealth and mental health interventions. I'm looking at those, and that's a lot more promising. And so when you're looking at those kinds of things, because those are the types of interventions that you're doing when you're looking at telehealth, you're doing the education, you're looking at mental health, you're looking at the stress, the anxiety, you're in one position. You can still see position and posture and movement. And we're talking population level. We have a funnel of care that I frequently talk about when I'm working with other practitioners, where we have the performance level, where like ideally as a society, we're doing these things at a population level. We start getting into systems. Where do we actually have the right to influence? Like, where do I have that access to influence things? What can we do? I am so happy if somebody does a program like Restore Your Core and never has to see a pelvic floor therapist. The first time I leaked was at Herman and Wallace, where I volunteered to be, like, I have no shame. I volunteered to be the model to be tested on. I had never leaked in my life until my first assessment, getting the internal assessment done because of the anxiety. Just and I leaked right there on the table in front of everybody. I didn't leak after that. Was that an accurate assessment of my pelvic floor? No. It was impacted by so many other things. And so I get really passionate when we start talking about like, what's a gold standard? How are we defining things? Is your internal exam even accurate? Or is it a measure of what that person is experiencing in that scope of time? And I'm speaking that from experience. Same thing. I've seen on pelvic floor PT things like, oh, you can't have a diva cup suction onto your cervix. I'm like, oh, okay, there's no evidence that shows that. Until it happened to me after my third kid, and I'm panicking in the bathroom because a diva cup is suctioned to my cervix. And so, like, we need to believe our patients and we need to look at what is best for their needs in their moments and then try to find out how do I meet this and meet it well and with quality. Because if we immediately dismiss it, we're not going to find what our clients need. Mic drop.
Right.
No, so true. Oh, go
Mhm.
ahead. Were you about to say something,
So,
Anne?
so what came up for me there is if you've ever, so I know we're talking about maternal health, but if you've ever had anybody with vaginismus or pain with sex, pain with insertion,
Yeah.
all of the ones that I've seen in the clinic never let me touch them to be able to do an internal exam.
I was going to say that exact thing is that not every patient even wants that. Um, and it requires
Exactly.
consent, right? Before being able to do that. And there's so much more that we can do. And I say we because I'm speaking both disciplines here that we can do externally, right? That we can be talking about and educating. And I relate this to because so there might be people on the call or those that are watching this later that actually don't know who I am. So I'm an acute care therapist by background, neurospecialty, but I do practice in this area, and I've started two programs at two different hospitals, one in Texas and one in Colorado. However, what was I saying? I also have memory issues. I need an assessment. Um, what was
We
I
were talking
saying?
about internal pelvic
Thank you so
exam.
much. So I relate this back to other populations, right? When we're talking about telehealth specifically or virtual care, it's not for everyone, right? I think we can all agree with that, that it's not for every single person, every condition, every diagnosis, but where it works, where it fits, then we do it. Right. And while you're doing it, if you recognize as a provider, this isn't working, or I think this person might need hands-on help or an in-person provider, that's when you're making the referral. That's when you're either, whether it's you or you're finding someone in that person's community uh, to to give them that access. Um, so that's just what I wanted to say.
Remember when I mean, this is it's just gonna be on those of us who are in the education space to really produce the research that occupational therapists, practitioners, physical therapists really should just be part of the maternal rehab space, the maternal health space. But it's a lot of the onus is on us as educators who are advocating for OT and PT to be at the table with OBGYNs, with midwifery, with doula care, with nursing support, with lactation consultants, you name it. We need to also be the ones that are producing the research. I mean, that just is like such a heavy expectation. Maybe I put it a little bit on myself as well. But I remember just trying to get case studies like crazy. And I remember kind of pressuring Jenna to just get this case study of a mom that had been readmitted back to the hospital, brain bleed, massive stroke. Within hours of discharge from her C-section, she's back in the hospital. Her ICU stay was about 9 days. And at the time, Jenna, and she's just like now coming to the point where she can actually give consent. The day that Jenna goes in and sees her for her visit and also, asking for consent is the day that she's reunited with her newborn for the first time since she's been home. And it's kind of those instances where it makes me realize like, wow, like so much of what we do, first of all, it does go under the radar in just general practice, whether it's acute care, outpatient, because a lot of our counterparts are getting a lot of the thank yous. Thank you for this, for saving my life, for the emergent surgery, for making sure we came through. Um, for, maybe we're getting lost in the whirlwind of just, the short maternity leave or the longer maternity leave, or maybe the longer referrals that we're waiting to see this patient population in the first place. Like after they have the prolapse or after they have the incontinence or after they have the this or the that, and we're kind of the last resort providers. So we're all, I think on this panel have been really working to expedite that earlier care especially during pregnancy where that person, has yet to make that emergency action plan. For that person who has yet to have the, unpredictable birth experience, we don't know, and the opportunity to treat that family as a unit. I think that we're in this space for the long haul, but we need the conversations like this to constantly almost like prove our value, and then also for the sanity of others, apparently, to distinguish ourselves a little bit. And I've still left this conversation. This is our second year in a row doing this, kind of in response to the same type of, you know, uh, messaging that we're receiving in the air about the questioning of, gold standard and stuff like that. Last year it was the same thing with OTs and pelvic health. It was just,
Mhm.
it's kind of the same almost response, kind of coming on the defense, but really I think we're probably offering the most comprehensive conversation of both disciplines actually talking. We're not just on the mic and just dialoguing, to ourselves about what do OTs do. I don't know. There's not a gold standard for what they do. There's a gold standard for what we do as PTs. We're just not doing that. We're inviting you all to the table, and we can't be more grateful to have both of you just give us a whole setting outlook from acute care, home health, telehealth, outpatient services when those patients are a little bit further along. And we're doing it in maternal rehab, which is a space that is welcoming everyone to support moms so that they can be the best that they want to be for themselves and their families. Anything that any of you would like to say as we just kind of close? The only questions we're finding is this going to be recorded? It will absolutely be recorded. Anything that you all would like to say as a send off?
Just real quick,
It-
what a privilege we get to be providers. Like that is a privilege too. Privilege isn't necessarily a bad thing. How are we using it? And so like
Mhm.
that's one thing. I also want to clarify, cash pay has a place too, because insurance also
Mhm.
does make it very difficult for a lot of us to do our jobs. But places where insurance plays more nice and acute care type things, like let's take advantage of the systems where we are
Mhm.
because we can. And so that's all my piece on it. I'm so grateful for y'all letting us be here. Thank you.
Yes, and to piggyback off of that, I feel like my goal is Kelsey's, but for everyone, like why can't we do it from a preventative wellness standpoint? Like why can't we just start getting this information out there so that way moms are empowered, prepared, informed. And that way if they have that provider that says, "Oh, you don't need PT. Oh, you don't need pelvic floor. You don't need this that." No, I do, and I'm going to get it regardless of whether you tell me I can or not. Because like it just boggles my mind that there are still OBs, despite the fact that ACOG says pelvic floor therapy is recommended, who will still say, "Oh no, you'll bounce back. It'll just be a little bit. You were just pregnant. It's not a big deal." Sir, yes, or ma'am, yes, it is a big deal. My back has been hurting all my pregnancy, and I haven't been able to take care of my other kids or go to work, or I had to go on disability. Like these are all factors that are affecting our patients, and those things are real, and if they can't get to you it's because they literally cannot. Anyway, let's all do a huge world community clinic and we'll just refer to each other that way,
Yeah.
honestly, because we need I feel like we, because of how big our country is, we and so hyper independent that we have lost the systems to have that tribe. And so now usually the privilege is being able to pay for that tribe. And so we need to get the tribe to everyone.
Agreed.
Hopefully it'll be soon.
Towards the end, we have just if you have even just 2 minutes for a quick 2 minute speech, I think we could probably even do it shorter than that. Amanda asked if you had a quick 2 minute speech, what would you tell leaders the difference between OT and PT and maternal health? Kelsey, you want to take that on?
I'm
You
going to
look
say the
eager.
same thing I said earlier about acute, okay, OT and PT and acute care. PT alone, maybe they're covering some of the same questions that OT and other ortho acute care settings might ask. How many steps to enter your home? What does your bathtub situation look like? Can a physical therapist ask that? Heck yes, they can. Is an occupational therapist going to go about it differently? Yes. How do we know they're doing it differently? What happens when we invite an OT into the room? The data says overwhelmingly that occupational therapists are reducing readmissions, and that's going to save the healthcare system tons of money. If they save 2 healthcare readmissions per month, that is the cost. That's more than the cost of your salary. So what are you doing to justify? Yeah, I got real nerdy. I was looking up how much a readmission costs an individual hospital. It's thousands of dollars, like at least 5 grand is the cost for a readmission because they can't have somebody else in that bed. And so how many of us are making 10 grand a month? Not a ton of us. Let's be real, right? And so if you can prevent 2 readmissions by having an OT coming in, asking about medication management, asking about habits and routines, asking, oh, do you have a bathtub or a shower? Not just ending there, but asking more of the details. Those are the things that are going to prevent people from coming back to the hospital. And we have the proof in other acute care settings, and it's a surgery there, and it's a surgery in other instances with a C-section or a hysterectomy or whatever it ends up being. Why would it be different in that kind of a scenario? So that's what I would do if I was in a hospital position advocating for both PT and OT.
And Duke saved over $500,000 for their health system by offering inpatient and telehealth rehab for their patients after birth. I think
That was only 18 months.
in an
In
18-month
18
trial period, $500,000. So yes, that's way above my salary. But
I'll take it.
I mean, I'll take it if I can, on a team of however many, provide services that would save my health system. I will absolutely take that praise. I have a question for you. How do you avoid duplication of services in acute care? Kind of piggybacking off of what Kelsey said, but how do you avoid that duplication of services?
Well, right now, that's something that we're figuring out because the referrals that we have been getting have been walking related due to epidurals having decreased sensation. And um, the one had a perineal tear. So I was like surprised that they sent me things other than C-sections. So I was just like, okay, this is cool. Um, because our department is taking ownership of it, we are looking at everything. And what I'm making sure is that if they have stairs, even though I know I can do that, I'm like, let me contact my PT counterpart because I usually will also have concerns of like, well, they heard the popping. Can you check their pubic symphysis? Can you do, there are other ortho related things that I know that I'm not able to do as well. And I would rather have somebody who knows what they're doing. And so I have them focus more on the functional mobility, whereas I'm doing functional mobility in the context of caring for themselves and caring for the baby. And then we both usually end up covering like energy conservation techniques, home modifications, DME. And I feel like when you have two people telling you the same thing, it stays more in your head than if it's just one person because you're sleep deprived and feeding a child. And hopefully that's the easy part because God forbid that they're in the ICU or the baby's in NICU or, all those other complicating factors.
Do we ever get that sorry, the acute care background here. But I just wonder, do we ever get that question for someone who's been admitted for like a heart attack or some other type of some other type of issue, congestive heart failure, something like that? Do do we ever argue, oh, we're overutilizing by having both OT and PT see them? I've just
We're taking
like,
too
why?
well care of them.
Right. I guess I don't fully understand why or where the problem is. If we have the opportunity for both disciplines to see individuals after birth, well, let's see how it goes. Let's see what we can both provide to this person. The person also always has a choice. They can always say, no, I don't actually want your services. I have never had that happen to me. I have a 100% success rate of when I offer my services. They have always said, yes, I'm very interested in that. And I'm sure it's very similar to OTs with this patient population. They want to return to the life that they were living before. They want to figure out, how am I going to navigate this new life that I now have to balance, and also remember who I was before, right? Like, what was that identity that I had before? And I just think that there is, I don't think we should immediately jump to this fear of overutilizing, when we struggle with even getting any of us in the room in the first place.
Mhm.
Um, but I will say there was another question off of that same question that was asking if if there was one discipline that can manage more in acute wait, let me see. If only one discipline is allowed. That was kind of the follow-up. So if only one discipline is allowed in the room, I'm assuming this person meant like PT or OT.
I mean, I've been really public
Is that
about this. I've always said occupational
me
therapy.
too.
And it's not like I'm a physical therapist, but when I talk to my physical therapy colleagues, and I was at a hospital here in Colorado Springs. I was part of that like initial program build at the one hospital. It was the largest birth center in the state of Colorado that we were successful with. The other hospital right in the same community was just like there was just no interest at all. Why? Because those PTs are stressed everywhere. Like, are they going to be asking about even the environmental things that they would ask somebody after a hip replacement? The environmental things that they would even consider on the onboarding, on my day one or day two of onboarding, I remember L&D actually called the unit, and the lead therapist, the charge therapist who was like onboarding me, he just got so upset because mom couldn't walk. Maybe it was, epidural related. Maybe it was actually labor delivery position, dorsal lithotomy. Let's be real, right? Couldn't walk. Maybe it was symphysis pubis. Maybe it was peripheral nerve. He didn't even want, he was just like, just keep her overnight. But he was so irate. But that same therapist, the policy there was that every patient after knee and hip replacement, they got 2 PT visits a day after knee or hip replacement. After shoulder replacement, I saw a 90-year-old gentleman after shoulder replacement twice a day. And he was so irate that labor and delivery called. Why do that patient, why do they need to be seen right now? Plenty of time in the day to have addressed that person. And you had me, right? And you knew who I was. And so, I mean, I'm telling you, for physical therapists and my counterparts, my colleagues out there, I love you all, but I know how stressed, intense you are in the acute care environment. And I'm learning more and more the more I talk with occupational therapists and practitioners, and I'm realizing the scope of what you all can catch, the mental health, the perinatal mood and anxiety disorders that you're catching way more than I would be thinking of, because I'm just like, okay, let's get out of bed. Sorry, but true. As an acute care therapist, if my ideal scenario would be vital signs are stable, you're able to mobilize, okay, you can leave. I'm not thinking of the big scope, right? At least if I'm a general practitioner. So if I could have one therapist that I know is going to do this bird's eye view, and possibly also just acknowledge that a person has 18 steps to get to their bathroom, or they don't have a shower chair, they just lost a lot of blood during delivery and they can't stand in the shower for a sustained period of time, I would want to have that practitioner that can then say, Rebecca, I think she would really benefit from your services. I saw an area that I'm not going to address, the pubic symphysis, more orthopedic, but I saw all these other things. I would love for an OT to really just let me know, where can I focus my services, right? And I know you are actually limited in most settings. We do not have enough OTs. So I'm actually putting more on you, but as a team, we do so much better. I agree with Kelsey. I agree with the research. As a team, for the patient's benefit, for the health system's benefit, we save the system money, we improve population health, and together we can reduce the mortality rate. And I am so on fire about that aspect after of our potential as a team to do so much better.
Better together.
Thank you so much. Thank you all, really, as a panel. I couldn't have chosen just a better duo of just providers. I'm so grateful and honored to call you my colleague. And we're really thrilled. I mean, for people who joined us, thank you so much for being here, for asking questions. And yes, this recording will be released. And so happy that you all were able to join us. Thank you.
Thank you so much.